sir. We can go live now.
Yeah, please. Okay. Shall I start?
Yes, please.
Okay, good evening, everybody. This is the first live series of International Cardiology Conclave, Series 1. And we are in 2022 now. And after crossing the 2 years of COVID, I think we are on the last leg of the COVID journey in Omicron 1. So let me start our conclave with introducing our two expert panelists. First of all, I would like to invite Dr. Dhiman Kahali, who needs no introduction in the realms of interventional cardiology. He's one of the most experienced interventional cardiologists in the national level today. And he's Director of Interventional Cardiology at PM Birla Heart Research Center, Kolkata. So welcome, Dr. Kahali, to the meet. I would also want to like to invite Dr. Smith Srivastava, who is a professor and head of the Department of Cardiology at PJMM Medical College and Dr. Brahm Hospital, Raipur. So welcome, Dr. Srivastava, to our meet. And hopefully we'll have a lot of discussions and your expert opinions regarding these wonderful topics, which we'll be discussing. So I'll just name the speakers first, and then we will start off with Dr. Aditya. We have our first speaker, Dr. Subra Aditya, who is Assistant Professor of Cardiology at RG Kar Medical College, Kolkata. Then we have Dr. Priya Mukherjee, who is Consultant Interventional Cardiologist at Fortis Hospital, Kolkata. Then we have Dr. Mandar Mahavisha, a good friend of mine, who is also the head of the department and consultant cardiologist at Tata Main Hospital. We also have Dr. Snehal Goswami, who is Associate Consultant Interventional Cardiology at Raipur, Narayana Hospital, Raipur, and Dr. Soman Chatterjee, Consultant Cardiologist at PM Birla Heart Research Center, Kolkata. First of all, I would like to invite Dr. Subra Aditya for presenting an exciting topic on the drug-eluting stent and polymer science. As we all know that the polymer has been one of the problems of these late stent thrombosis and stent thrombosis with the drug-eluting stents. But we'd like to hear from Dr. Subra Aditya exactly what stage are we in of interventional cardiology where the polymer is not a problem anymore. So over to you, Dr. Aditya, for your presentation. Thank you. Can you, yeah, we can see your slides, yeah.
This evening, we are going to discuss is polymer science. Important topic nowadays in interventional cardiology. In the chart shot, which approach is best? If we start with the history of this, the polymers used in the first generation of disc was blamed as the cause of chronic inflammatory response that leads to stent-oriented adverse clinical outcomes. That is, most feared one, stent thrombosis. So there are strategies to mitigate the adverse effects. That was development of biocompatible, durable polymers applied nowadays. In the contemporary days, durable polymer days. And another strategy is nowadays evolving, that is the development of a biodegradable polymer which dissolves with time. That seems to be more attractive in the biological aspects. Applied in the recent days, biodegradable polymer days or BPDs. Now in the following slides, we will try to understand the basic is involvement or evolvement. Consider the evolution. So it starts with management of coronary artery. Next comes the PTC, then 1950s. There is the era, the starting of stent. Improvement, it comes with the drug-eluting stent. 2010s, beginning of second generation drugs. That is improvement, technological, and the drugs as well as drug delivery system and second generation drugs. Device related complications. Biodegradable polymer when we consider first state in the year of 1987. So the first generation drugs was Aclitexin and Sirolimus. Have polymers and basic skin structure, that is metal, and the drugs polymers. With time, all of these are states into the generation of state. So in the year of 1990, first human cycle. Nowadays we are considering third generation states. Consider second generation of states. Drug, polymers, must element family, resolute family that uses deuterolimus. Simultaneously, evolved from alloy and polymer. Consider biodegradable polymer. But till date, beyond a doubt, it is still unknown whether contemporary consider stain. Stain design is about balancing units. Stain thickness, number of rings, versus tuning design, stain flexibility, and on the other end, there is number of rings, side branch axis, side branch recoil, resistance to the LCD. These are all the balancing factors we have to consider when we consider stain design. So there are different patterns that we consider in designing, and the technology used by the different things allowing advantages as well as disadvantages. So in science, giants, we have excellent radial strength, excellent longitudinal strength, low metal to artery ratio, its energy compromised longitudinal length with the design, excellent radial strength, wiring from 80 on industry. As well as there is oxido strength with excellent longitudinal strength, high metal to radial artery ratios. In case of onyx, excellent radial strength. Longitudinal strength is also good, but high metal to artery ratio. Stent materials. Nowadays, it is almost all balloon expandable stents. First, it was developed with stainless steel alloys. It was corrosion resistant, biocompatible, relatively high radiopacity. Nowadays, these are cobalt alloys, biocompatible, high radial strength, excellent radiopacity, thinner strut possibilities. So strength of the metal is important as we consider strut thickness to be reduced. So strength has to be sufficient to maintain the radial strength. we consider the polymer, it has been evolved over time, and nowadays we are considering biodegradable. Physiologically, that will not be there after some time. Most of these are from 12 to 24 months, and gradually there will be no polymer produced in the metal. So there will be no late inflammatory response. Stain-related events will be lesser in this concept. So polymer type, it has been changed and it has been investigated further, and being investigated for a search of ideal polymer. If we consider the duration of different polymer bioresorption, is a chart showing that. So if we consider the drug, the ideal drug will be, there will be the inflammatory reaction has to be stopped. Nowadays, all numerous drugs are considered cytostatic agents. So cell remains viable without proliferation and hindering the proliferation of the cell. So if you consider clinical evidence, Giants consistently shows reduced platelet aggregation or activation. So thrombus is lesser with Giants as it is. Preclinical trial shows that Giants is less thrombogenic. It is less inflammatory also. So we can consider short-term durability and prevention of latent regular stem thrombosis. Safety of durable polymer as compared to bare metal stain, it is obviously proven. So if we consider clinical trials, high stain thrombosis rates for biodegradable polymer at 1 year, when the most of the polymers have gone away. But we are rather somewhat unexpected result that events are increasing by 1 year. Statistically significant acute stain thrombosis with biodegradable polymer. Giants showed excellent outcome compared to all other days in ACS patient and 12 months. That has been seen in post-reproduced positive ACS trials. Century 2 embodied trials also comparison with other Giants. So we are given rates for Giants instead of access in real world patients, but in ideal training trial. So definitely thrombosis was significantly lower in Giants field. People to shows no difference in platelet rates between Synergy and LTS earlier generation strains Thomas Edison class. At 3 years, we still show no benefit of Synergy biodegradable polymers. All of these trials mostly shows these are non-inferior to our standards contemporary second generation strains. In the concept screen first with biodegradable polymers, results were attractive because initial comparisons were done with the first generation strains. But when it comes with the second generation strains, they are, most of the trials, they are non-inferior, but superiority is not yet proved beyond doubt. No additional benefit for Synergy versus Thomas in simple patient population, that is evolved to trial. Biosense trial at 5 years, recent evidence showing similar patient outcomes for BP6 versus DP6. So Giants proven to be still now safety and efficacy wise, still numerous biodegradable polymer stains still not proven all and above our standard second generation stents. ISA test 4 also taking that follows data DPCs equals and resolution DPCs giants. Talent trial at 2 years, this also reports not very much favoring added advantages of EP test over durable polymers. Only approved 80 approved days with longest follow-up data of 10 years, that is the examination trial, the everyless conducting strains. So this is the data summary of 10 years trial data. 10 years safety and efficacy data in complex to all comers population known as in the trial. So ultimately, the clinical data support claims of superior safety or effectiveness of biodegradable polymer use over durable polymer use. Yes, we do find this is still on the based of evidence beyond doubt. No, we don't find any big difference in clinical outcomes between DP tests and current DP tests. Thank you.
Thank you, Dr. Shubhra Aditya, for your beautiful slides. There was a little problem with the audio. I think your slides made up for it. So over to you, Dr. Kahali and Dr. Srivastava, for your comments, and then we'll move on to the next case. Over to you, Dr. Kahali. Dr. Kahali, probably you're muted, I think. We can't hear you. Yeah. Dr. Kahali, I think we can't hear. Shubhra?
Dr. Vinayak, I think you're also muted if you're trying to say something.
Dr. Srivastava, you can put your comments, please.
Surely, sir. It was a very presentation with a lot of clarity, and it showed the development from early days to present scenario. And still, we find that we have different school of thoughts and different beliefs, and it is yet to find that a stent which is suiting for all conditions. Sometimes we are more worried about the radial stent, sometimes we are more worried about the trackability of the stent, and therefore we do have, which is fortunate that we do have a lot choices where we can go for. And definitely for Zion's platform, it has proved its worth, and it has made our lives a lot easier than we had before. And probably we'll be more interested in the cases rather than discussing the platforms. We all have used it, and we are well aware of the advantages that we have.
Thank you so much, Dr. Srivastava, for your kind comments. We move on to our next presentation by Dr. Priya Mukherjee, and he will be presenting on a complex PCI. So over to you, Dr. Mukherjee, for your presentation.
Thank you. Thank you very much, respected chairperson, respected moderators. Now, I would like to thank Abbott for giving me the opportunity to present one of my cases. I am just sharing my screen. Is it visible?
Yeah, we can see you now. Yeah, we can see your slides.
Yeah, my voice is audible here.
Yes, it is audible. Yeah, please carry
thank
on.
you, thank you very much, thank you very much. So this is a story of a 83-year-old male patient who had a STEMI during the presentation in our emergency department, and the patient was in a shock with the requirement of NORAD double strength 5 ml per hour, and ejection fraction was 35% with hypokinetic LED territory. Regarding comorbidities, he has T2DM. We took the patient for angioplasty, and eventually we sent gene expert, and during the plasty we have the news that patient is also COVID positive. And this case was done only 15 days back, and at that time there's a massive outbreak of your Omicron in Calcutta, and almost in our cardiology department 50% staff got COVID positive, and we have a very difficult time at that time due to this staff shortage, and we sometimes we didn't get our best technician or best nursing staff during the procedures. So that was a event, and in this case it was also like that. The patient case was very critical, and the patient was referred from a hospital outside, and the left hand side, this is a fast ECG, and which shows there is multiple leads, there is ST segment depression but no ST elevation. But when the patient presented in our emergency, this is in our left hand side, in our emergency ECG, it clearly shows there is a ST elevation in V2, V3, V4, and there is some small QF is also there. Though the transport time was not very significant, the patient reached from the peripheral hospital to our 40s within 90 minutes, within 1.5 an hour, 90 minutes. So this was the angiogram. Now this is a LED. The ostial is very tight, we can appreciate, and some tortuosity I think you can appreciate. In the caudal, epicaudal view, so you can appreciate how the critical is the left main disease also, almost 80 to 90% disease, and RCA is a non-dominant, which shows also a significant disease, but it was non-dominant. Circumflex was a very large vessel, and you can I think appreciate the circumflex ostial lesion is also very tight, and starting from then the circumflex also have some disease, around 70 to 80% irregular plaque is there. Now this is the hemodynamics I have presented when I actually doing the angiography with a 5 French tiger, and even the 5 French tiger showing significant pressure damping. So there is no doubt is a very bad critical LAD with significant left main involvement. Patient was not in a good shape with a cardiogenic shock. So so what should be strategy? I was very much confused, and I told I didn't get my expert cath lab brother and sister during the procedure. Now left main stenting crossover, either crossover strategy or two-stent strategy. So this was my first dilemma. Now if you see, there's a circumflex ostium was significantly diseased, and the circumflex is quite big. It's a dominant vessel, so I don't think that leaving the circumflex with the such tight disease is justified. So I think two-stent strategy in the case, though it is very difficult in such critical scenario in a ACS, STEMI, and your shock situation. Now regarding which strategy, either crush, either decay crush or mini crush or nano crush or tap technique I have to use. Now tap is a very beautiful technique. So I can finish the case very easily if I put a stent from the left main to LAD and just rewire the circumflex and then you put another stent. But I had doubt that during stenting the left main to LAD, such critical circumflex disease, I may lose the circumflex, and the patient may go into further shock, and there may be a catastrophe. So I think that first there should be something to be done in the left L6 ostium also. So I didn't accept. I didn't go for the tap technique. And regarding this 3 crush technique, now see mini crush, now decay crush and nano crush, they have multiple steps. Particularly decay crush have multiple steps. So in this critical scenario, I choose mini crush technique to do the case, because it can be done very quickly to finish the case. Now, definitely we need a hemodynamic support. In our cath lab, in our hospital, we have 2 IABP machines, but unfortunately at that time the 2 were occupied by the surgical department. So I didn't get the balloon pump at that time, and some logistic issue I told regarding the crunch in the staffs, in the good staffs in the cath lab during this pandemic, this Omicron outbreak. Now I started the case. It's a femoral root and there is a JL7 French catheter, and I dilate the ostium of the LAD and the left main with a 2.5 and the 3 millimeters balloon sequentially, and I did a balloon dilatation of the circumflex also, starting from that mid part and then gradually coming to the proximal part of the ostium. And the ostium was quite opened very nicely, so it was a good that there is no such calcium in the case. I was so this is a angiogram after doing this balloon dilatation, and there is the patient was still maintaining the hemodynamics at that time. I had a cardiac anesthetist and he was actually giving some medicines. So now I put a giant stent in the distal circumflex. It is a 2.5 millimeter giants into 32, I think, that time. And after this putting the stent, I took a giants 2.75 millimeter in the LCX and 3.5 millimeter giants from the left main to LAD. So after checking some views, now at that time there was some problem in the hemodynamics. You can see there is already the patient started having bradycardia, and so I have to be very fast in the process, and I deployed the circumflex stent, removed the balloon in the circumflex, and quickly I have to put this stent from the left main to left main to LAD. The patient, I have to give some intracoronary adrenaline at that time, because at that time the BP was very low. So I give some intracoronary adrenaline, and with this maneuver and this quick stent deployment, the patient was again in a better shape with a BP in the 3 digit. So after that, I got some time definitely, and I took a balloon for proximal optimization. It's a 4 millimeter balloon, and I go in a high pressure. It's a almost 22 millimeter atmosphere pressure, and then I recross the circumflex and took a 2.75 millimeter balloon and sequentially post dilated the stent starting from the distally, and took a 3.5 millimeter NC balloon in the LAD. Now this is the steps of the kissing. So first I inflated the circumflex balloon in a high pressure around 16 to 18, and I saw there's a good opening of the balloon. Then I inflated the LAD stent balloon with a 3.5 millimeter in a high pressure, and then this is a simultaneous kissing balloon at that time, and it was a moderate pressure around 10 to 12 atmosphere pressure. Now at that time, when removing the balloons, actually my assistant, who is not very expert in handling such critical cases, he actually pulled the wires. So at that time it was very difficult, and I found that a portion of the stent is hanging in the left main, and I tried to cross, but I didn't basically force too much, because we have done the final kissing balloon and the result was quite satisfactory. Yes, I would miss the final part, but I think it was better to leave the patient. And one thing also I missed at that time, I was also planning to do a IVAS at that time, but due to this the problem, I also don't try to push the IVAS through the start, because it can actually destroy the geometry. So I shifted the patient, and the patient was gradually tapered from the NORAD and quite improved. And there's some problem in the lungs with this your COVID, and they give some remdesivir and steroid, and the patient gradually improved. So this is the case. So it's the final shot. So you can see there's a good flow in the both LCX and your LAD, and the stent is quite expanded. Stent is expanded nicely. So this is the cranial view of the LAD. You can see, you can appreciate. So the flow is good and TME3 flow at that time. So my take-home message from the case, that sometimes you need to perform complex angioplasty in ACS patient with hemodynamically compromised state. So they are definitely a challenge, because the patient may crash anytime during the procedure, during ballooning, during stenting. So hemodynamic support, balloon pump is necessary when feasible, but sometimes it is difficult to get those hemodynamic support in our day-to-day practice. And I can advise something. The ADR, intracoronary adrenal, is very good in such cases. Sometimes you can bail out such cases with intracoronary adrenaline. And regarding the mini crush technique, I think it is very suitable for doing such cases, just when you have to be very quick in actually deploying these stents, because the patient may crash and at any point. Other crush technique, either decay crush or nano crush, they have some extra steps, and so I think in some critical cases it is better to avoid such complex techniques. And tap can be tried, but sometimes it is not suitable, like my case. So I didn't try to do the tap. And yes, you need a balloon pump when feasible for doing this case. Thank you very much for patient hearing.
Thank you, Dr. Priya Mukherjee. This is a very complex case which you have managed, and there are a lot of points for discussion, I'm sure. So I give the podium to Dr. Kahali for his initial expert comments. Over to you, Dr. Kahali.
I think Kahali's voice is muted. Something.
Yeah, we can't hear you, Doctor.
Yeah.
Am I audible?
Yes, we can hear you now.
You are listening to me now, something.
Yes,
okay,
we can hear you, Dr. Kahali, please.
Case which Priyam presented, and it's a very complex one also, because in COVID atmosphere, and the patient had a COVID positive features, and then also the patient was in cardiogenic shock. We know that in COVID, lots of thrombus is there, and it's a very complex one. But I think he has managed the situation very well and done extremely well. And I agree with him that decay crush or other complex gullot, etc., are very difficult in such cases, and one should go for easier techniques. And he has done it quite well, I think.
Thank you.
Yeah. Dr. Srivastava?
What was the reason that we had bradycardia during the procedure? You had some.
Actually, when I
right?
Hello.
Yeah.
Yes, Dr. Srivastava.
Yeah. I think at that time when I was placing the stent in the circumflex, putting the stent in the circumflex, and also there's a stent in the left main to LAD. So there is some compromission on flow at that time, I think, and that is the cause of bradycardia and the dropping of the blood pressure. So that is a very crucial. So because we are actually compromising the left main, and the whole the blood supply is getting stopped. So this is I think very crucial because left main is the majority of the blood supply. Almost all the blood supply is through these.
Yeah,
main vessels.
non-dominant right. So
Yeah.
sometimes the guide gets sucked in or it gets deeply hooked, and then you have a. But it was a very well managed case. I must congratulate you. And the other question is that you are not afraid of giving an intracoronary adrenaline in this situation.
Yes, sir, because I have experienced that in such situation, the bailout situation, that when the patient is crashing with either a thrombus or the patient having bradycardia, BP, low BP, intracoronary adrenaline actually works like a miracle. So it can actually immediately it can actually increase the change the hemodynamics with the increase in the blood pressure and your heart rate also. So it is a very good drug in our armamentarium. We can use in such a critical bailout situation, I think. So only one thing, the patient may have VT after giving intercoronary, so you have to tell your staff, be ready with the paddle. So you may need to give a shock anytime. So this is the only precaution you have to take.
And third is that would a single stent strategy would have from the start would be a better in COVID scenario, because I found that in my personal experience that COVID, it results in a lot of thrombus burden. And then phenomena of no reflow or slow flow is very high. Sometimes even we have left patients in COVID who are COVID positive and presented with thrombotic occlusions, that we had left those patients just trying after a thrombus aspiration or some ballooning. And after a month of NOAC or other therapies, the patient has had a clean artery.
Sir, yes, definitely. In such situations, single stent strategy, crossover strategy should be the first choice. If I could do that. But definitely, it was a left main bifurcation Medina 111 case, and the circumflex was not like 50% or 60%. It was a 90% disease. So if I'm doing actually case from the left main LAD, I can lose the circumflex and the dominant circumflex in absence of RCA. So I can actually the patient may crash. So that is why actually I choose to go for two stent strategy. Otherwise, definitely in all cases, not only COVID, if I can finish the case with a single stent strategy, crossover strategy is the best.
Yeah, I think you've done a very good job.
I think it is a beautifully done case, and I agree with Dr. Mukherjee that it was a two-stent strategy to begin with because of the tightness of the ostium of the circumflex, which you just mentioned. And if you had lost the circumflex, I think you would have been in big trouble. And other thing is about the non-availability of balloon pump. I think it's a very, very difficult scenario, particularly in this kind of cases where you have to do a two-stent strategy upfront and with the cardiogenic shock situation. I don't know about intracoronary adrenaline, how good it is in real life scenarios, but if you have got some anecdotal experience, okay, we accept it. But I think it is always prudent that we should have some kind of intra-aortic balloon pump or any other mechanical support, particularly in this elderly situation. But I think given the scenario of the COVIDs, we all know what we have faced in the last couple of weeks in the cath labs and in the hospitals. You've done an excellent case on an elderly gentleman, and many congratulations, Dr. Mukherjee.
Thank you. Thank you. Thank you very much.
We will move on to our next present. Yeah, Dr. Mamanda Shah. Yeah.
Just one query I had for expert panelists. Like in this case, because the wire in LAD came out, he could not do POT. In such a situation, I could see that wire is still there in circumflex, and the stent has been there from the right from the ostium of left main, some few struts protruding into aorta. In such a case, keeping stent into, taking balloon over the wire, circumflex wire, would it not be possible? Not pushing the balloon through and through into circumflex,
right,
keeping it proximally into left main.
I fully agree. But actually, the two wires were we lose the two wire at the time. And if you saw carefully, I can again share my screen. I again stented the LCX, but it was from the start, from the 5 millimeter, 4 millimeter from the actually ostium. So almost 4 to 5 millimeter start was hanging. and I can show, if you allow me to share my screen.
No,
I can.
I think
that's
we
fine,
saw
that's
that. Yeah, Dr.
Yeah.
Shah. I think Dr. Shah,
Yeah.
what you mentioned is correct, but I think he lost both the wires. That was the
Yeah, I
reason.
lost both the
Lost
wires
both
at the
the
time.
wires.
Yeah, he could not do
Yeah,
it.
so I couldn't do the pot. So this is a fact.
Thank you, Dr. Mukherjee. So Dr. Shah will present our next case. Dr. Shah has been doing excellent work in Jamshedpur. We are aware of it. So let us see what kind of case you have for us, Dr. Shah, for this meet.
Please give me a moment.
Yes, please.
Am I audible and is my screen visible?
Yeah, both are good.
Both. Okay. So, good evening, everybody, respected seniors and my dear friends. There are lots of similarities in clinical profile between previous case the Dr. Priyam presented and my case, in the sense that he was an 80 years old gentleman. My patient too had a recent anterior wall MI and ejection fraction was 35%. But similarities and over there, my patient was much more stable. He was not having any hemodynamic compromise, not on any inotropes. And he presented late, in fact, with post-infarct angina. So this is my lesion. Once again, a dominant circumflex. RCA was very small and non-dominant. And we can see critical lesion in ostium of LAD and another tandem lesion soon after in proximal LAD. There is a minor plaque in circumflex ostium, but then having said so, in a 80 years old gentleman with recent MI, we decided that we'll stent only from the ostium of LAD. So that is what we do. We've taken a 3.5 non-compliant balloon and pre-dilated it and then stented it from the ostium.
Dr. Shah, your slides are not moving, I think.
Oh, it's moving. It's
my
moving.
slides not moving?
Yes, it's moving.
Okay, it is moving.
Yeah.
Okay, fair enough. So then we deployed stent 3.5 by 23 millimeter drug-eluting stent. And then we see that there is significant pinching of circumflex ostium. Now, that was the time when we did not have FFR in our lab. So our FFR has got procured very recently. So conventional teaching is whenever you get a branch which is pinched, you do FFR, and if based on FFR, you decide whether to leave it alone or to stent it. But in my case, we had already an infarcted LAD and a very large dominant, super dominant circumflex, very small RCA. So I was not comfortable to leave this alone. So actually this case was being done by my colleague, Dr. Tapan. And then after this stage, he sought my opinion regarding what needs to be done. And I was not quite comfortable leaving this alone. Now my stent is there from ostium of LAD with a couple of one strut protruding into left main. So in this case, we thought the best strategy would be to consider LAD stent as LAD as a side branch and proceed with DK crush. So that is what we attempted. So we wanted to crush the side branch, that is LAD stent, with a 3.5 compliant balloon. Unfortunately, the balloon would not cross. So then we took a 1.5 millimeter compliant balloon, dilated it, and then sequentially further pre-dilated it with a 2.5 compliant, and then 3.5 could cross. You can see that we have removed the wire from LED and then crushed the side branch. And you can see that, I don't know whether it's visible, but I've tried to show that the side branch is adequately crushed. So rewiring, I mean, not rewiring, wiring of side branch across the struts. But now balloon could not be negotiated across the stent struts into LED. So then we thought maybe we'll take another wire and try to go through another strut, but even this did not help. So none of my balloons would go. So then once again, bailout was a 1.5 millimeter, 1.5 by 6 millimeter balloon. So we passed that across to just dilate the struts and make space for bigger balloon to go. And after this, balloon could be negotiated into LED. And then we did first casing with a 3.5 millimeter non-compliant into circumflex and a 3 millimeter non-compliant into LED. So that effectively makes left main diameter of 3.5 plus 3 is 6.5 into 2 by 3. So around 4.3, 4.33. So which was quite okay. And then this is the result after first case. It looks to be quite satisfactory. Then we took stent starting from origin and deployed it. I do not know what is opinion of expert panelists over here, but we have found that whenever we want to position stent from ostium of left main, then cranial views, especially iliocranial view, opens up the ostium quite nicely. So we tend to deploy all our ostial left main stents in iliocranial view. And then we did first pot. Unfortunately, I don't have dilated balloon image, but then that's okay. After first pot, we did post dilatation of circumflex using a 3.5 non-compliant balloon. And then wire was again negotiated into LED and final casing. Once again with a 3.5 by 12 non-compliant in circumflex and 312 non-compliant in LED. So final pot with a 4.5 by 8 non-compliant balloon. And this is the final result. So this is pre and post images. And I don't know whether you all can appreciate the stents, but they seem to be quite well expanded and the results seem quite good. In this patient, we have been following up. This was done about 4 or 5 months back. Patient has been doing quite well.
Thank you, Dr. Shah, for this. Yeah, carry on.
No, fortunately for us, the patient did not have any hemodynamic compromise, so we could follow all the steps of decay crush, assuming LED to be a side branch.
Okay, thank you, Dr. Shah, for this case. I think there's a lot of points for discussion on this case. So over to you, Dr. Kahali, for your initial comments, and then we'll go to Dr. Srivastava.
Kali, you are again not audible.
Listen now. Am I audible now?
Yes, we can hear you now.
Everything is at maximum, you know.
Yeah, we can hear you now, Dr.
I don't
Kahali.
know
Please
what
carry
has
on.
happened today. So, you know, can you listen to me, Binayak? Otherwise,
Yes, we can.
Okay.
Yeah.
So Binayak, just one simple question. I think he has done a very good job because the ultimate result is excellent. And he had a lot of problems in negotiating the Ware's balloon across the circumflex and also LED. That's quite natural in such cases, but the ultimate result is very good. Just a question to you, Dr. Shah. When you put the stent from the ostium, that's a good thing because a shorter stent we might dislodge while engaging the catheter. So what is your policy of deploying it from the ostium?
Uh,
Because certain
I mean,
points are to be
what?
seen when we
Yes.
deploy the
So a
stent
couple of things
from the
that we
ostium.
normally do, which we have not done in this case, we tend to put a wire into the cusp, aortic cusp, so that the catheter does not get sucked into the left main. So in this case, we did not need to do that because the catheter, we could place the catheter outside and we could still deploy the stent. But in majority of cases, we do put one wire into aortic cusp so that the catheter is prevented from getting into the left main.
Putting it across from the ostium, what we should do, that the inferior border of the stent, we should keep it little proximal to the ostium. Okay, otherwise it will miss. And the superior border
Yes, yes.
just distal to the ostium. Okay, then it will
To the
prevent,
ostium.
it
We
won't be
don't.
dislodged, and also the stent will cover the whole of ostium. So inferior border, we have to keep it little before the, little proximal to the ostium, and superior border, we have to keep it little distal to the ostium. Then the placement will also be proper, ostium will be not missed, and secondly, it will not be dislodged when you are negotiating the catheter. And your policy was very good. I was watching the procedure that you have given a little longer one because shorter stents, if you put, then it may be dislodged. So it's a good policy. So we should remember this while doing this one. And while dilating the side branch, we should take it 0.25 millimeter more, the balloon, because the orifice of the side branch is oval. It is not completely round. So if we have to take a little 0.25 more, it dilates the ostium in a good way. And I think you have done well. Your circumflex was pinched, no doubt about it. So we had to tackle the circumflex. And I think the ultimate result is very good and you have done it extremely well. It's very good. Congratulations.
Thank you, Dr. Kali. Over to you, Dr. Srivastava, for your comments.
Yeah, probably as you have rightly mentioned, most of us must be practicing cranial view for deploying a stent, and would imaging would have given you some help in this case.
Definitely, imaging would have helped us basically because we empirically went with 4.5 millimeter balloon for post dilatation. We do not know the exact size of left main. So imaging definitely would have helped. Unfortunately, that was the time when we did not have. But our FFR IVAS has been a recent procurement. So we do have FFR IVAS now, but that was the time when we did not have it.
To my expert panelist, can I just put a question to Dr. Shah and to the panelist? One is that if you had a FFR, I think sometimes you are very surprised that the FFR value, even if you have an optical illusion of a tight stenosis, the FFR value would be actually optimal. So that is one thing. Now that you have FFR, you can actually correlate your imaging techniques. And the second one is that very surprised at the amount of pinching you had because you had placed your LED stent just at the ostium, and this was actually coming out in quite a obtuse angle. So I was a bit surprised about the amount of pinching which you had in the ostium of the LCX. What do you think, panelists?
Yes, because the first view also was only on caudal view that was shown, so that did show some disease. But that it had some abnormal origin of LCX also. It wasn't that it was like coming out perpendicularly to LED. So you're very right. Probably a FFR would have saved so much of labor and act of bravery, but then it was a right decision at that time, that place. And probably it may be that some use of vasodilators may have also given you a clue that LCX may not need a intervention.
Dr. Kahali?
Both Dr. Antonio Colombo and Dr. Ajib Latif, in their deliberations, they have told that in many literatures, they have told that if the lesion doesn't seem to be more than 75%, the FFR is normally more than 0.8. So by looking at the lesion, if it is not a very tight, I think Binayak was also telling the same thing. So they have, correlated the findings, and they have found that if the lesion is not very, very tight, like 80%, 90%, 95%, then normally the FFR is usually negative. So we can have some correlation, because in our setting, each and every patient, we cannot go for, today we are in Singapore Live, Binayak's old place. And, Ashok was showing the EBC and, that Cheng's DK crash. So the lesions in Chen's group in DK crash, all of us know it. The syntax score was much higher. So he went for two-stent strategy. The side branch lesions were much longer, 15 millimeter plus. But in ABC main, it was only 7 millimeter. The syntax score was much lower, 22, 23, like that. So as we're discussing, and EBC, they have routinely gone, even if there is no pinching, they have routinely gone for kissing balloon inflation. So that was mandatory, and therefore they were putting more of, unless there is some dissection or something odd with some flow disturbances, no flow, slow flow. That is the only indication where they have put the second stent in the side branch. Otherwise, they were not putting. And as a routine, they were doing kissing balloon inflation. But I think that you have done an extremely good job, and the result is fascinating. And I think it's very appreciable. Thank you.
Thank you, Dr. Kahali and Dr. Srivastava. Dr. Srivastava, I believe you would be leaving at 8:30?
Yeah, 8:30 I have to.
Okay. So thank you so much for your presence. So if we will meet up sometime again.
Yes, sir.
Okay, thank you. So Dr. Shah, thank you for your excellent case. There's a lot of points of discussion, and I'm sure that with your availability of FFR and imaging now, things would be much, much easier for you, and it would be, you can correlate yourself what you did in your life before FFR acquisition and now with the FFR on board. It will be much of a difference.
Yes,
so thank you so much for your case. So we move on to our next presentation. It would be by Dr. Snehal Goswami. So Dr. Snehal will be discussing a complex PCI. So Dr. Snehal was with us in RN Tagore, I believe, in Kolkata. Now he's with NH Raipur. So over to you, Dr. Snehal Goswami, for your presentation. Dr. Goswami, can you hear us? We can see you, Dr. Goswami. We can't hear you. Dr. Goswami? Okay, I think we'll move on to our next presenter. Then we'll come back to Dr. Goswami. So Dr. Suman Chatterjee, if you can present your case now, and then we will have Dr. Goswami as our last presenter. So over to you, Dr. Chatterjee.
Good evening, Dr. Dev. Good evening, Dr. Divankar sir, and the expert panelists and the other speakers. Myself, Dr. Suman Chatterjee, going to present a case of left main disease with LED involvement. Now I'm sharing.
Yeah, we can see your slides and hear you too. And carry on, also, Dr. Chatterjee.
So my case scenario, clinical scenario, was a 52-year-old lady, non-diabetic, normotensive, had a recent history of anteroseptal wall MI 4 days back, managed conservatively outside, now presented here with a post-infarct angina, and her echo shows mild to moderate LV systolic dysfunction with LVEF of 40% with preserved anteroseptal wall muscle mass. So we have done the coronary angiogram, which shows there is a thrombotic lesion in the mid LED along with a distal left main disease and a minor disease in the ostium of the LCX. Now, coming to analysis of the coronary angiogram, C has a significant left main distal disease with osteoproximal involvement of the LED. Mid LED has a tight thrombotic disease. Ostium of LCX has a minor disease. Offered for CABG, denied for surgery, has taken for PTCA for ongoing chest pain. Now, this is the iliacaudal view of the coronary angiogram of this patient. After wiring, there is a significant narrowing in the distal left main around 70 to 80% with involvement of the ostium of LED, and there is around 20 to 30% plaque in the ostium of the LC. So after wiring, we had put a direct stent to the mid LED thrombotic lesion with a 3 into 16 millimeter disc, followed by pedalation of the ostium of the LED and the left main distal portion of the patient, and then the ostium of LED and the left main was stented with a 3.5 into 12 millimeter disc, followed by port with 4 into 8 millimeter entry balloon, and the post dilation result, there is still some amount of pinching in the LCX, and there is a from the very beginning there is minor plaque in the ostium of the LCX. So we decided to go for a kissing balloon inflation. After rewiring done, the kissing balloon inflation in both LED and LCX, ostium of the LCX, with a 3.5 into 12 millimeter balloon in LED and keeping a 3 into 8 millimeter balloon in the ostium of the LCX. And this is the post kissing balloon result. Ostium of the L6 now looks good, and this is the final result. And this is the still image of the final views. Still there is some amount of disease persist in the L6, but after kissing balloon inflammation, I think this is a good result, and better to not put another stent in the L6 on the L6. Keep it alone. And patient was symptom free, and after in the follow-up, patient is symptoms free and is doing well. So coming to the take-home message, IVAS usually recommended for left main disease, though our Kerala is not IVAS equipped. So I did not go for IVAS in this case. What is a crucial step for KCL kissing balloon inflammation for technical age? PTCA has an equivalent result with CABG in low to intermediate syntax close patient with left main disease, considering the 5 years MES result. Thank you.
Thank you, Dr. Chatterjee, for this wonderful case. Before handing over to Dr. Kahali, may I ask you that why did you recommend a CABG to begin with, offer CABG to this patient? Because I think in a center where Dr. Kahali actually is an operator, I don't think these kind of cases do require CABG as the first option. Do you agree, Dr. Kahali?
the option of CABG as the first, because it's a class 2A indication.
Yeah.
Today in Sync Live, your place, we had a lot of discussions regarding this, that why we don't give, PCI as the first option. So that was one of the questions which was discussed at length. And many were of the view that it should come as class 1A indication. So that's why I think Shumon has given the option of CABG. And I do agree with Shumon that that's a very good step he has taken. And I also appreciate the case. He has done it quite well because it was a thrombotic lesion in STEMI, atmosphere, and a lot of, ballooning, decay crash, this and that are difficult, and, that causes dislodgement of the thrombus. So it's a simple one. And I also appreciate putting a single stent strategy, because the side branch, as we are discussing, if you do a FFR or IVAS, of course, in taking the decision that whether you would go for a second stent, IVAS is not the factor. Actually, it is FFR. And as we are discussing, the lesion seemed to be 40%, maximum 50% at the ostium of circumflex. And there was good TIMI3 flow, no thrombus load, and KBI has been done nicely. Only thing I can suggest that, Shumon, you could have done a second KBI, kissing balloon inflation. Sometimes that improves the result a little, but I think it was very well done, and I appreciate that keeping it at 40%, the ostial circumflex lesion, I think it don't disturb. And as he told that the patient is doing quite well, which is anticipated, I think it's a good job done, simple, and he has done pot also, so I think it's good job.
Yes, Dr. Kali, I think you just mentioned about a kissing balloon, because that is so important in these kind of cases, which you discussed in Singapore Live today, that routinely to do a kissing balloon inflation for these kind of cases to give an optimal result, and then have a FFR to really guide you to whether you want to do another stent or not. And provisional stenting in this particular case was so correct step to take. So a wonderful case, but I still don't agree in an acute scenario to give whether CABG should be the first option. I think I would disagree with you. I would always have, if I have Dr. Kali with me in the center, I would definitely
It should not
would
be
put
in acute scenario,
PCI much ahead.
there is no place of CABG.
Yeah.
I do agree.
Dr. Priya Mukherjee, do you want to make any comments on this case?
Yeah. Actually, the strategy was excellent. I think always single stent crossover strategy is always I think superior than the two stent strategy, particularly when there is a borderline plaque in the circumflex. And in this case, definitely there is only 40 to 40% like plaque. And even after doing the final kissing balloon, I was all happy with the results, because I don't think there's no need to put a stent in the circumflex. Only one issue I have, that last cine, the ostium of the LAD, I think there should be a more there should be a more caliber, or there need some more post dilatation regarding the ostium of the LAD, because I think just from the ostium ostium is not properly inflated, dilated. So this is only my comment. I think otherwise it's an excellent case.
I think I appreciate the the thinking process and the rationality which Dr. Suman Chatterjee has beautifully taken in this particular case. I think, Dr. Priya Mukherjee, if you had imaging, that would solve your issue, whether you have a position of the stent or not. But if you do not have imaging, I think I would accept this result. Dr. Kali?
Yeah. I think it's very appreciable, and it's true that the ostium of the circumflex has little under dilatation, but up to 10% it is okay. Of course, it's near the left main. Priyam is true about that, but I think it is acceptable, because in all cases we cannot expect that it will dilate, especially in these precarious conditions where the patient is sinking down. We have to do the job. I think side branch stenosis in the ostium is well taken. I think it is acceptable. And the LAD stent, there is little under dilatation at the ostium of the LAD, no doubt about it. I think some sort of post dilatation with a higher balloon would have done a better job. But anyhow, it's well taken, it is acceptable, and 10% under dilatation, I think it can be accepted, no point. I think, Shumon, you have done a beautiful job, and it's very much
But actually, I
appreciated.
have done post-dilation with 4 into 8 millimeter balloon, and in
Good
this
job done.
thrombotic situation, I do not want to further push post-dilation and
Yeah.
more WS.
Yes, I understand your concern, because I think in a thrombotic scenario, too much of dilatation, post-dilatation may cause a problem. So I do understand your concern, and I like your thinking process and how you have approached the case. Thank you so much, Dr. Chatterjee. So we will move on to our next presenter, Dr. Snehal Goswami, if he's ready. If you could stop sharing, Dr. Chatterjee, your slides. Dr. Shah, do you want to say something about this case? I didn't know you were around, actually. I couldn't see you. If you could say something about this particular case.
Like all of you have very aptly discussed. I think it was under given circumstances, it was very, very well done case.
Okay,
So
thank
in
you.
the thrombotic lesion in ACS scenario, I too would not like to interfere too much. Keep it as simple as possible and get away. And especially with the kind of result that he has got, I think it's quite an appreciable thing, sir.
Thank you. Thank you. Dr. Goswami, are you ready with your case?
Can you see my screen, sir?
Not yet. We can hear you and see you. If you can start sharing your screen.
Now, sir? Is it visible?
Not yet. Not yet.
Okay.
Okay. Take your time. Take your time. No issues.
Actually, my laptop is having some technical glitch, so I have logged in with
Okay.
2 devices.
Okay.
And yeah, I think this will do.
Yeah, we can see your slides now.
Okay, sir.
Yeah. Thank you. Please carry
Okay,
on.
apologies from my side, and just a quick thing to mention. I was trained in Arctic, sir. You were part of a lot of discussions back there. I hope you can remember me vaguely, but we
Yes, I
used
do.
to-
No, not vaguely. I do remember. Yes.
Thank you, sir. And Dr. Happy to see Kali sir here. We used to hear him clearly during our CSI meets and STEMI India and various conferences. Happy to see Dr. Smith Srivastava here, who's a pioneer of cardiology in Chhattisgarh. So trained in Kolkata, working in Raipur. It's nice to see your trio, and with some nervousness and some confidence, I like to present few cases to you. Actually, this is a collage of cases, which is my target is thrombus containing lesions. I'll go in a ascending manner. This first case, I've titled this as nothing was needed. This was a relatively simple case. This was a MI in a young gentleman. He was 39-year old, no comorbidities, no COVID infection. He just came to us with inferior wall MI. Window period was 5 hours. We loaded him with DAPT and took him for primary. And
your slides are not moving.
okay,
Dr. Goswami. Yeah.
লিভ দিয়ে বেরোবো না, এমনি এটা ঠিক আছে না? না না, লিভ করবো না।
What you can do, Dr. Goswami, you can talk across your slides, and then we can have a discussion if there's a problem. You can talk through your slides.
Yes, I am actually not able to flip through the slide. I'm just. No, it's not flipping.
No, you talk through your slides. Just talk through your slide. We'll discuss them.
Okay, sir. Actually, I wanted to show you some videos, and the slide is not going to the next one. Let me reshare, sir. Just give me a minute.
Okay, okay, sure. Don't worry.
It's not going into slideshow, so I don't know. I think there's some.
It's okay. Don't worry, Snehal. Just talk through your slides. We'll discuss them. Some other
Okay,
time we'll see your slides
okay,
again.
okay.
Yeah.
So the first case was a relatively simple one. So there was a grade 2 to 3 thrombus. He was a 39-year-old gentleman. We don't want to stent him. So what we did in this first case, we just put him on a GP2B3A inhibitor infusion for 24 hours. We did a check angio. And next day, what we found was thrombus was completely gone, and there was a TIMI3 flow in RCA. Post this, what I was trying to show in the second case was this was a 62-year-old gentleman, and he again presented to us with infero-posterior ball MI. He was thrombolized outside with streptokinase. We did coronary angiography. There was a grade 4 thrombus. Here we used export, and we aspirated a significant amount of thrombus through the RCA. There was a stenotic lesion, and this time we stented the lesion. So these couple of cases were were smooth sailing. Actually, which I was interested on was my third case, which I titled that case as a ping-pong thrombus. Now, this gentleman, he was relatively young. He was a 49 years old gentleman, and he had a grade 5 thrombus. RCA was tortuous and was completely occluded in mid segment. We could not negotiate the vessel through Shion blue wire, so we took a high tip load whisper extra support. After crossing through whisper extra support, we did couple of export runs using thrombuster, but the lesion was as it is in the beginning. It was completely occluded. Post that, we took a balloon and tried to plaster the thrombus. After doing a bit of dottering with a small balloon, we took a 2.5 mm balloon and tried to plaster the thrombus. But again, to our surprise, the lesion was same. It was completely occluded in the mid segment. Post that, we gave intracoronary Tyrofeban and Corandel. And we took couple of export runs, but this time what we managed to do was we pulled the thrombus proximally into the RCA. Now this thrombus, there was some flow distally, but this huge thrombus, which was grade 3, came and got settled in the proximal RCA. Post this, again, we took export. We did a couple of runs with export again. We again gave intracoronary Tyrofeban and Corandel, but this thrombus again got dislodged and went into the same position where it was earlier, that is in the mid and distal RCA, occluding the complete vessel again. Post this, we took a export run for the nth time. This time we lost the count how many times we have done the export, and patient had some hemodynamic compromise. Left system LAD was deceased, but culprit was RCA, so we were running behind RCA. This time with nth run of export, we managed to bring in some flow. It was TIMI2 flow, and entire PLV was filled with thrombus. PDA was having TIMI3 flow, so we decided to put him on Tyrofeban infusion. In clinical vignette of this patient, he presented to us a bit delayed. He had window period was around 24 hours. So I think thrombus was organized, and it was typically what we angiographically called as an angry thrombus, which has migrated proximally, distally, proximally again, distally again. And we lost the count how many times we were playing this ping pong with this thrombus. We put him on Tyrofeban infusion for 24 hours. And he had a significant drop in hemoglobin, because we have taken the export run so many times. The hemoglobin drop was around 2 grams per deciliter. And we put him on inotropes for around 12 hours. Post recovery, we took a check angio shoot 48 hours later. This time we didn't stent the vessel. There was significant reduction in thrombus. Thrombus was around grade 3 in entire PLV. We got rid of the thrombus from proximal RCA and distal RCA. PDA was flowing, so we deferred stenting him in this case. And because there was no significant stenotic lesion, the entire RCA was around 4.5 millimeter in length, and PDA PLV say around 2.75 and 2.5 millimeter in diameter. Post this, we just kept him in clinical follow-up. He's doing well, and there is some recovery in RWMA. Still, there is hypokinesia in basal inferior wall. The last case, which I labeled that as dilate another day. Hope this technical glitch might have not interrupted. If given opportunity, I'd like to show this next time. In this dilate another day case, we had a tortuous RCA, which was again crossed with the intermediate via. Post this, when we stented the RCA, again, the thrombus was grade 5. This caused a significant slow flow, and there was a significant wasting or dog boring noted in the mid segment of the stent. Although we did a sequential pre-dilatation, starting with 2 millimeter balloon to 2.5 millimeter balloon to 3 millimeter balloon, and that was the reason or the culprit why we got a significant slow flow in the distal RCA. Post recanalization. So what we did, we just let that dog boning there. We just pre-dilated it with 4 millimeter balloon. It was a large RCA, sizing around 5 millimeter. So we left it there. We kept him on Tyrofeban infusion for 48 hours. And after 48 hours, when we did the check angio, we optimized the stent using a larger balloon with no slow flow this time. So my take home with these messages, these cases are that the thrombus needs individualization based on the clinical vignette of the patient, based on the grading of thrombus. And angry thrombus is always, we have to be cautious. Export, although European guidelines end up stating to be cautious use of thrombus aspiration. If the thrombus is anyway higher than grade 3, we should always use GP2B 3A inhibitors and export catheter. But individualization of treatment on case basis is must. And last, patience is the key. At times you can get stuck, like the third case that I mentioned, the ping-pong thrombus. We were stuck around for 3 hours in that case, fluoro time of being 16.5 minutes. So I think patience is the key. At times you can get stuck with such cases, but persistence and patience is the key. I'm sorry for this technical glitch. I can't show you the slides. I might have, it might have been good to have some input from Binagdev sir.
Sure, yeah. Dr. Goswami, thank you very much. I think these are wonderful cases which you would have seen. Maybe some other forum will definitely invite you to show your videos again. But I think there's a lot of discussion points. And the first thing I would like to mention to our esteemed speakers that in this era of COVID, I think there has to be a recalibration of the how we deal with thrombus, because this being a thrombotic milieu which we run across in this, particularly in the COVID times, the whole idea of thrombotic lesions causing in this kind of STEMI and even the non-STEMI would need a recalibration. That's number one. Number two is, I think, as Dr. Goswami very correctly has done, to leave first case alone with Terifibran on board, and then, sequentially he has shown this, particularly the ping pong case which he showed, that is a difficult one. But I think it is always better if you have a problem that you, in a thrombotic case, that you leave it alone with this antiplatelets on board, and then come back another day and re-address the issue. So first of all, I would ask Dr. Shah, then Dr. Priya Mukherjee, Dr. Chatterjee, and also Dr. Aditya to discuss about the case. Dr. Shah first.
It have been really very interesting to see your cases, especially your second case and the third case, third case and the fourth case. Now, one comment that I had to make is for these cases where, like you stated, that there didn't appear to be any stenotic lesion and it was full of thrombus. So, and even after giving Terifibran for say 24 to 48 hours, when you recheck, there is still grade 3 thrombus present. So these cases, typically, if you keep them on one of the NOACs, rivaroxaban, and then you follow up after 3 months, do a check angio, very often you'll be surprised to see that the entire artery is quite clean.
Yes, sir.
So I would also like to know opinion specifically on this point from the expert panelists.
I think, Dr. Shah, you're very correct, because I think the stenting is for stenosis. It is not for thrombus. Thrombus causing an occlusion needs to be removed either manually or with your pharmacologically. So that is the thing you have to. If you can prove that there is no stenosis, you can jolly well leave it without any problems. If you put them on intravenous antiplatelets or on the NOACs, which we currently have, and come back another day to see exactly what's happening. Because stent, if you put it in a thrombotic milieu, I think you are in big trouble, because you are adding on to another layer of problems which you already have. So that is my opinion. What about you, Dr. Mukherjee? What is your opinion? You are muted, Dr. Mukherjee.
I am also very much eager to see the cases of Dr. Goswami, and I am sure that in some another forum he could actually present the cases. And if there is opportunity, I can also share some of my cases with a large thrombus and how I manage those cases. Now one thing, what is my comment is that I always believe that thrombus is one of the greatest enemies of angioplasty, because thrombus, because it can actually very difficult sometimes to get the flow, and repeated thrombosuction, ballooning, intercoronary GP2B3 inhibitors, all have been tried, but sometimes you cannot get a good flow, particularly in the AMI cases with the late presentation and RCA. So they are the important factors of this large thrombus. Now, one thing, just I can, I need the opinion of the panelists also, and then the speakers, that there are some anecdotal evidences that intracoronary tenecteplase or a thrombolysis in some bailout situation, though it is very risky, because with this Brilinta, loading after Brilinta, there is a very high, there is maybe a risk of your hemorrhagic complications. But I just want to know the opinion of the panelists. So in such bailout situation, what is the role of intracoronary tenecteplase? For my experience, I have given 2 cases. One has very good improvement in the table after 15-20 minutes, but another patient, I didn't have any improvement after giving the intercoronary tenecteplase. So I just want to know the opinion of the panelists.
Dr. Mukherjee, this is a very, very interesting topic which you brought up, because I could speak for hours on this, because we've been involved in this scenario since 1990, 89-90, when we started our intracoronary stuff, those days we didn't have tenecteplase, we had altiplase, we had streptokinase and all this stuff. But we found out when we did angioscopy in these patients, which was the first imaging modality which we had, and those days the IVUS was coming around, we saw in angioscopy that you had white thrombus and you had red thrombus. So if you give this fibrinolytics for red thrombus, you had actually a clearance. But if you give it for the white thrombus, you did not have any clearance at all. Those were a platelet thrombus. So the differentiation between a platelet thrombus and a red thrombus, because this is a problem. So basically, in cases where we have predominantly red thrombus, we had successful thrombolysis. Even systemic thrombolysis was good, and intracoronary thrombolysis were also useful. But if you had white thrombus, then your intracoronary thrombolysis didn't work. So that was one of the reasons the intracoronary thrombolysis is not probably a very, very useful thing. If your systemic thrombolysis doesn't work, intracoronary thrombolysis is very, very unlikely to do its job. So that is my experience since 1990. We have done a few studies on that. Dr. Goswami, are you showing us some videos?
Yes, I'm just trying, but it's not playing.
Okay. So, Dr. Shah, what do you think about the intracoronary thrombolysis, which Dr. Mukherjee had just brought up?
I don't think there are any studies with newer thrombolytics, tenecteplase, etc. But streptokinase, there have been studies and they have clearly showed more harm than benefit. So in my practice, I've never tried giving intracoronary, although there have been a couple of instances where I was tempted to try out, but somehow I've never dared to venture into that territory.
You see, what happens is now that we have the ability to, with imaging, to actually see what kind of thrombus we're dealing with, and we have so much powerful antiplatelet agents, the NOACs and all these intravenous agents, we are in a good position to actually deal with the thrombus. But in a procoagulable state, when actually you're dealing with acute STEMI, if you see a large artery, even hepatic arteries, where you have so much of thrombus burden, you can never clear the thrombus in one go. It is very, very difficult. I think, as you just mentioned, and Dr. Mukherjee will also concur with me, that in these cases, it is good to leave them on these anticoagulants for a while and then bring them back to the cath lab if the patient is stable in the meanwhile, and redo them again. I think then you will see exactly that thrombus is cleared, and then you have a benefit of seeing whether you have a stenosis where you need to stent or not. So that is a good way of doing it. In an acute scenario, in a procoagulable state, it is always the anticoagulation and the antithrombotic agents which requires more than angioplasty with stenting. That's my take on the subject. So, Dr. Goswami,
yes, sir.
Are you able to show us quickly?
No, sir. No, it's still stuck. Okay.
Okay, fine. Yeah, Dr. Shah.
Dr. Vinayak, taking the topic further, what is your opinion regarding intracoronary GP2B3A inhibitors, intracoronary tirofiban? We have been giving intracoronary tirofiban, and what we noticed is that if thrombus is very fresh, like for example, catheter-induced suboptimal hyperenization, and that's the reason why if there is catheter-induced thrombus which has gone into the vessel, that is one scenario where intracoronary tirofiban does tend to work. But if it's a MI which we have taken after say 24 hours, 48 hours, in these scenarios, typically it will not work.
I think you are absolutely correct. If it's a man-made stuff, the intracoronary probably does work. We have a video which is playing now, is it?
Yes, sir. Yes,
good.
That is excellent.
Yeah, we'll extend our thing for a couple of few minutes more.
Yes, sir.
You just show us the video. Yeah, just
sir.
the videos. Yeah, that will be fine.
This is the first case, sir. This
is
39-year-old male, and this is the a thrombotic lesion, nothing stenotic there.
Okay.
This is the RCA in cranial view. You can see just distal embolization of thrombus in the PLV.
Okay.
And left system was fairly clean, nothing there. So we gave him tirofiban infusion for 24 hours, and we did a check angio. There was absolutely nothing in RCA post infusion, and we left him without stent. This was the second case, as I told. He was thrombolized with STK. Left system was fairly okay. Right system had grade 4 thrombus. There was some tickling of contrast post thrombus. We did an export run here. This plastic was a safe sailing. As you can see, there was a significant amount of thrombus aspirated through 6 French export. And post this, there was a stenotic lesion at the crux. We stented it with 3.5 into 29 drug-eluting stent. And we post dilated it, no slow flow, TIMI 3 flow. And this was a smooth sailing. Which case, this one, the ping-pong thrombus, I think so this one was the case which made us toil hard. As you can see, there was a thrombus, a good organized thrombus in the distal RCA. And left system was fairly clean. There was faint collaterals which was filling PDA. There was a muscle bridge in mid LAD, a non-significant one. So we gave him loading, kept him on tirofiban infusion, no reduction. He was outside window period, no reduction in clot. Multiple thrombosuction using 7 French export. No change in the clot. We tried to plaster the thrombus using a sequential balloon dilatation. No improvement in flow. Thrombus is as it was there in the beginning, in the first angio shoot. We did a repeat thrombosuction. Intracoronary tirofiban and corandil. We gave this using an export. And now to our surprise, we ended up with this. This thrombus was completely occluding the distal RCA. There was some faint tickling of contrast post distal RCA, but this thrombus, I can say grade 3 thrombus came and got lodged in proximal RCA. Now we again started doing rethrombosuction. Some flow there, which is a better flow encouraged us to do one more run of thrombosuction. But what we ended up is just where we started. Again, the thrombus got lodged into the exact same point with a similar appearance. Again, multiple runs of thrombosuction. Again, an intracoronary nicoran and tirofiban. And again, this thrombus got its position in the proximal RCA. So this was just like a ping pong game. But second time when it came proximally, the PDA started flowing better, which encouraged us to go again and do a thrombosuction. I think we can have a varied opinion because this landed patient in a bit of hemodynamic compromise. He was on inotropes and reballooning. As I said, I lost the number of counts, how many times we have done this thrombosuction. And this was the final result. There was no stenotic lesion. It was entire artery was filled with thrombus. So now we kept him on infusion, and at follow-up, as Sir Mukherjee sir correctly mentioned, sir, we kept him on dabigatran, triple therapy for a month, ecosprin, clopidogrel, and dabigatran for a month, and then we kept him on a dual therapy, clopidogrel and dabigatran. And we followed up him, and in non-invasive parameters were absolutely fine. Only basal inferior hypokinesia is persisting. There is no MR, and patient is stable. So we deferred stenting here. And the last one, this is the third case just prior to discharge. As you can see, we were quite happy with the result. There was no stenotic lesion, grade 3 thrombus persisting all around the distal RC, but there was significant reduction in the thrombus burden. And this was the last case, dilate another day. This was the left system. This is the tortuous RCA, completely occluded in mid part with grade 5 thrombus. We started with Chion blue, could not negotiate it. Took a small balloon support, could not negotiate it. Changed the wire to a higher tip load, whisper extra support. Can cross it with whisper extra support. Vessel straightened out a bit. And sequential balloon dilatation. But mind you, we got a significant slow flow post this sequential balloon dilatation. Why we ended up doing sequential balloon dilatation is because there was a significant waste noted with 2 and 2.5 mm balloon. So it was a tight lesion. There was no calcium angiographically. We were assuming it's a fibrotic lesion. We ended up dilating with 3 mm balloon. And this was the result post sequential balloon dilatation, but still, as you can see in mid RCA, it is tortuous and significantly tight stenosis there. We took a 4.530 onyx stent, and as you can see in the second picture, there was a significant waste while deploying the stent at nominal pressure of 1280 atmosphere. We post dilated it cautiously using 4 mm and 4.5 mm balloon, but stent was not optimized. To avoid further slow flow, we gave intracoronary tirofiban and nicorandil, made sure that coronaries have a TIMI3 flow, kept patient on a tirofiban infusion. And then we took him up post 24 hours. As you can see, the stent was not properly optimized. Now there was no thrombus here post tirofiban infusion. We took a balloon and optimized our stent properly again, this time with 4.5 and 5 mm balloon. And as you can see in the last frame, the corner one, this was the size of the vessel after optimizing the stent properly. So we waited for 24 hours for post dilatation. We made sure that after stenting, that patient has TIMI3 flow. And after 24 hours of tirofiban infusion, we achieved this. So this was the take home, sir.
Good, very good. So what did you learn, Dr. Goswami, from all this?
Sir, all I can say is a couple of things, that individualization of therapy, and at times going, as sir mentioned, about this thing, that intracoronary thrombolysis. So I just, well, while doing these cases, post these cases, I did some literature search and found out that CSI has mentioned this statement: if your wire is not crossing for 60 minutes, never hesitate to do an intracoronary thrombolysis, no matter which agent you prefer. I think Sir Shah sir was right that there are some papers regarding streptokinase, regarding recombinant tissue plasminogen activators. There are still a lot of ambiguity, but if your wire is not crossing, never hesitate to give intracoronary thrombolysis. And apart from this, individualization of therapy is very important. And as you correctly mentioned, stent is never for thrombus, stent is for stenosis. So wherever possible, just try to defer stenting in thrombotic lesions, especially if it's a high thrombus burden, anything more than grade 3 thrombus.
And I think, on a lighter note, keeping patients in long tiring cases is key to success. That's exactly what we did today, because
Yes.
you had a thrombosis in your internet, and you
Yes.
tried and tried and tried, and you were successful. So I'm very, very
Yes.
happy that you could show us your cases. We
Yes.
all learned a lot from all these presentations. Thank you, Dr. Goswami. Thank you, Dr. Shah, Dr. Mukherjee, and Dr. Chopra for the wonderful cases, Dr. Kahali and Dr. Srivastava for the expert comments. So we'll meet up again sometime in the near future, maybe offline, maybe online. Let's see. And I would really want to come to Dr. Shah's center to see how he's doing with his new tools. And definitely, some of these days we'll probably be over there for a live case, maybe. Why not?
Yes.
Love
So,
to have you over there. Yes.
and Dr. Mukherjee, we would also want to
Yes.
see some of your thrombotic presentations in your next
Sure.
case presentation. Okay, so
Yes,
that thing is always there. And Dr. Goswami, all the best for all the things which you are doing in Raipur. So thank you very much again, all the panelists and my speakers. And I wish you good night and have a safe couple of weeks ahead.
Yeah.
Good night.
Good.
Dr.
Good night. Good night, sir.
Goswami, just before we sign off,
Yes, sir.
just wanted to know, what did you do to fix this thrombus in your internet, in your computer?
Sir, actually, my laptop is, you can say, a vintage laptop. So what I did basically, I shared this. I have logged in with 2 devices. There is some problem or glitch with my audio in my laptop. I think my speakers are not working. So I'm talking to you using my cell phone, and about sharing my screen, there was some issue with my laptop, but I kept doing it again and again, and finally it picked up once.
This is
So
this is exactly the way we do our TV shows, Dr. Goswami. That we have
Yes, sir.
we speak on our cell phone and the images come through our laptops.
Yes,
This is
sir.
how we go live on our TV shows.
Yes,
So
sir.
well done, very well done, Dr. Goswami. Thank you so
Thank you,
much
sir.
again. all
You
of
backed us back then during our training phase, and you're continuing it, sir, right now.
Yeah,
I was so happy
okay.
to see you in the panelist groups.
Okay, good,
Thank
good, very good. Okay. Thank you,
Thank you.
everybody.
Thank you.
Thank you, everybody.